and final Making Maryland Healthier, a conversation with Chancellor Jay Perman this morning. So just some housekeeping. I wanted to introduce myself. I am Tracy Kodak, the CEO of Healthcare Access Maryland. And over the last year, we've been providing this opportunity to interview and have a conversation with different people across the state. We interviewed and had a conversation with Ivan Bates, the new Baltimore City State's attorney. We had a wonderful conversation with Jane Miller, and today we have Chancellor Jay Perman, And so we are super excited for our third and final one with the Chancellor. The goal today is to really discuss what makes a healthy community and strategies and solutions that can be implemented to improve the well-being of Maryland residents. We have lots of conversations around this, and this actually helps Maryland and HCAM specifically be more strategic in our work. We are a nonprofit that has been around since 1997 with a focus in helping individuals and families enroll in health insurance, whether it's on Medicaid or the health exchange that was established in 2013. We have over 200 employees, many that are on here today, so welcome, that help us work with the community to enroll them in health insurance, help them navigate the healthcare system, and then focus on social determinants of health that really create barriers for individuals accessing those healthcare services. That could be transportation, food access, the ability to determine whether they are going to pay an electric bill or transportation to their doctor's appointment. So some of that will come up today in our conversations. I want to thank our series sponsors, TriBridge Partners and Window Nation. You will be muted today for the conversation. So if you have any questions, please feel free to add them in the chat. If you're just joining us, please introduce yourself in the chat and where you're joining us from. And I am going to introduce Chancellor Perman. And actually, I've known him for a couple of years, but I feel like he's probably the best person to introduce himself. I'm super excited to have a conversation with him today. So welcome, Chancellor Perman.
Thank you so much, Tracy. It's a pleasure to be with all of you. I've long admired what HCAM does, so it's a particular honor to be in front of you.
Thank you. We are happy that you could take time out of your very busy schedule. And I think today I want to ask you a little bit of, we're going to go over a couple topics, but I think I first want to kick it off with your career journey from medicine to serving as Chancellor of the University System of Maryland. So can you tell us about that journey and what drew you to higher education?
Well, I'm going to do my best. First of all, I'm sure like all of you, it's not easy to talk about yourself, but you asked me. So I'll tell you a bit of a story. I'd also point out, Tracy, that you ask the question that many others ask or think of asking, but you do it in a very polite way. I mean, what you basically asked me is, what is a physician doing with the nerve to think he can run a higher education system? That's really the question here. And I'm not defensive about it. I'm actually honored, and I think I can make a case for why I'm doing what I'm doing. So let me tell you a little bit about myself without going overboard. I have always been in academic medicine. I am a pediatric gastroenterologist. I take care of children with digestive diseases or nutritional issues or liver problems. That has been my career. And notice I'm saying it in the present tense because even though I have the responsibilities for the University System of Maryland, which is a 12 institution system plus 3 regional higher education centers serving about 165,000 students. Even though I have that responsibility and that is my principal job, to your question, it's tied to healthcare and vice versa. And one afternoon a week, and we can talk about this later, I go over to our ambulatory center at the University of Maryland, and I see patients. So I continue as a physician. I've had, in this journey that you're asking me about, every job in the book in academic medicine. I'm like that guy that people often talk about in a corporation, maybe starts in the mailroom and then has every job and eventually maybe makes it to the corner office. That's sort of like me. I started out as a young assistant professor at the University of California, San Francisco, where I really learned what it meant to be a physician in an academic setting, conducting research, teaching, a particular love of mine, and seeing patients, of course. How did I get to Baltimore? From there, Johns Hopkins University was interested in standing up a program in pediatric gastroenterology. This is about 40 years ago. So here we came to Baltimore, and I've been in Baltimore most of the time ever since. I've chaired pediatric departments, and importantly, in this journey, which gets to higher education, I had the privilege of being the dean of the College of Medicine at the University of Kentucky. Now, you notice from what I said already, I've largely had my career localized in urban environments. So I learned a lot of stuff in Kentucky, ladies and gentlemen. I learned about rural healthcare and what goes on for poor people, disadvantaged people who live in Appalachia, as opposed to inner cities. I learned a lot. It was good for me in continuing on with this answer to your question. And then, as many of you know, I came back here to Baltimore happily to be the president of the University of Maryland, Baltimore, where so much of what we do in the university system is nested in terms of the healthcare professions, as well as social work, as well as law. Here's what I learned in this journey as it relates to what we're talking about here today. For me, being a physician and taking care of folks, taking care of children and their families, that's been a lifelong lesson in humility, because it finally became evident to me that a physician like me has the easy part of the job in taking care of people. You know, my job, right, is to get the diagnosis right. That's what you want from your doctor, and prescribe the proper therapy. That's the easy part of the job. And you all know what the hard part of the job is. The hard part of the job is addressing everything else that they bring with them to the patient visit or into the hospital bed. It's what, Tracy, you already alluded to. It's those social determinants of health, which physicians, I'll speak for myself, but I think it's generally true, are not particularly good, not particularly trained at solving, certainly don't have the time. The stuff you mentioned, no grocery stores in their neighborhood with healthy food. It's fine for me to tell a parent in my work, you know, you got to feed your kid better. I say it politely, I hope. But, you know, if you're living among corner stores where a soft apple is unaffordable, that's foolish talk to them. Unsafe neighborhoods with poor housing, creating stresses that actually cause disease or exacerbate disease. And what you mentioned, no transportation, low-paying jobs, poor housing, I may have mentioned that already. These social determinants of health. And I learned as a physician that if you don't solve those, it's not likely that the brilliance of making a right diagnosis and prescribing the proper therapy is going to work. So what has this all got to do with higher education? But you can answer the question as fast or faster than I can. This may be just a bit hyperbolic, but I don't think it's particularly overstating the case. If you want to fix all of that stuff for folks, you make sure that they have access to a good education, a quality education, so that they can lift themselves up. And so that the rest of us are educated enough to solve those problems, which are probably less expensive to solve than treating them for it. So that's it. It became very clear to me that if I wanted to make a difference to these issues writ large, I should put my efforts into making sure that kids get educated.
Thank you, Chancellor. And what a journey from California to Kentucky and to Baltimore, and really using that vision to focus on higher education. So obviously your perspective, you have the physician perspective and working with the patient, and the educator perspective. And we talked a little bit about what makes a community healthy, but what does a healthy Maryland look like?
Well, this is in no particular order of importance, but you know what I'm going to start with. A healthy Maryland looks like a place where all children go to good schools, where all children are acculturated to the idea of getting an education. We lose too many kids by the time they're 12 or 13, and they don't grow up in that kind of a thought process, in that kind of a culture, so that they understand the value proposition of being educated. But the rest of it all follows from that. You know, a healthy Maryland is a Maryland where families earn a living wage, where people have access to high quality health care, where we make investments in communities, whether they're urban, whether they're rural, so that housing is better, so that environmental issues are minimal, so that communities are strong. That's what a healthy Maryland is to me. And I'll tell you, if we were able to do all of that, if we had the will to do it, we would have a healthier Maryland.
Well, I hope either Governor Moore is listening or someone sends him the recording of this conversation today, because I think it's really important and very focused on the strategies that he's trying to impart across the state in his vision for a healthier Marylander.
I have full faith.
We'll make sure
even though he's my boss, I would say that.
So one of the other things that I'm sure you have come across in working with patients and families is low health literacy as a barrier, right? We see it all the time in accessing care and becoming healthier. You may have the will and the initiative to want to do that, but what can physicians do to better communicate health information to their patients to make informed decisions?
Well, I'm glad you brought that up because, Tracy, health literacy is an important issue for me. I realize where I fail. I watch others fail, to remember that, and this is no fault of the patient, this is no fault of the family. We make assumptions that our pattern of communication, what we do in the office, in laying out our thoughts to a patient are often unclear. And you can't count on the patient or the family, can you, to tell you they didn't understand? Because for many people, to say, I don't understand, is embarrassing. So you have to be proactive about it. You have to avoid what we so often do as healthcare providers, which is to use our jargon or our acronyms. We use initials. Why should anybody else know what that means? And we don't take the time. I think this is part of health literacy, what I'm going to say. We don't take the time to talk to families and patients at an appropriate level regarding the mechanisms of the disease, regarding how the therapy works. This is also part of paying attention to health literacy. You get a better result when the patient, the family understands what's happening here, how this came about, what you're going to do about it. And then at the end, it's good to take just a moment, a precious moment. Every moment is precious in our high volume healthcare environments, but to take a moment and say, have I made it clear? Did you understand what I said? If not, please ask me questions.
Absolutely. I think we have to encourage that. And also, I think as an educator, I'm sure you see this in ensuring that as we're training the next field of physicians and nurse practitioners and nurses, that is a conversation and something that's threaded through their experience in school, that they walk out of their learning experience and their internships and their residencies to be taught the same philosophy related to low literacy, related to health literacy. And this is not even touching upon cultural barriers, language barriers, and ensuring that we're addressing those as well. So thank you for that. Yeah, it's super important. Yeah. And I know University of Maryland has a very strong health literacy program at College Park.
And we've made that very visible around the system because we have healthcare education programs, as you all know. Many are concentrated in Baltimore, but we have nursing programs. We have physical therapy programs. We have PA programs. We have pharmacy programs distributed around the system. And health literacy is pertinent to all of those professions. So we take advantage of the discipline we have at College Park to spread the news.
Absolutely. Absolutely. I was in an emergency room with a family member a couple years ago, and we were just waiting for her to be seen. And there was a gentleman next to her in the bay, and his hearing aid batteries had ran out. So there was no way that he was going to understand anything that the nurses and doctors were talking to him. And one of us ran out and got him hearing aid batteries so he could hear what was going on related to his health. But something as simple as hearing aid batteries or hearing aids in general are another barrier to care for the population.
Tracy, if I could just insert, we're talking
Yes.
about literacy and specifically health literacy. One of the things that all of us who are healthcare advocates and healthcare providers need to remember is that some of the people we see don't have literacy. And again, just as I said when I mentioned that people may be reluctant to say they don't understand, it's embarrassing. Many people who can't read will not tell you they can't read. And if the ability to read is important to the care plan, you have to pick that up.
Absolutely. And that is a very challenging piece of the puzzle that I'm sure takes a really long time for providers and the health community to actually learn about, because it is embarrassing for people that are going through that or experiencing that, I'm sure, to be able to share that with the community or whoever is helping them. So,
When my colleagues and I suspected
mhm,
in the office, even at the risk of creating embarrassment, but trying to be sensitive to it,
of course,
we ask from time to time, can I just check? Can you read what we're giving you?
have to in a sensitive way, and that's again why I'm excited that you sit in the position that you sit in and that we're having this conversation, because it is so critical for those in the healthcare space to recognize these nuances. And it requires so many people at the table, right? And this is going on to my next question. Addressing social determinants of health is just doesn't rely on the physician or the nurse practitioner or even the hospital social worker. It is a true team effort. And I know that you use a very strong team-based approach at the University of Maryland, Baltimore, where you still practice, which I love. Who are the key members in this team and why are they so important?
Well, you've hit it, of course, on something I love to talk about. So thank you for that, Tracy.
Of course.
Recall that I said earlier that it finally dawned on me that I, as a physician on a team, have the easy part of the job. And I also use the word humility. Let me start by responding to your question with a little story. Years ago, when I was at Hopkins, I realized that delivery of care in the home was becoming ever more essential in the totality of what we have to offer patients: home care, healthcare in the home. And I also realized that in the academic setting, even though physicians and nurse practitioners would sign orders for healthcare at home, I'll speak for myself. I didn't even know what I was signing. You know, it looked like the therapy was right, but I didn't know much about home care. So we decided at Hopkins that this ought to become part of our education of trainees. This ought to become part of our healthcare delivery model. So I started a pediatric home care program at Hopkins, which still exists. And one day, my colleagues requested a nurse to go out to the home of an 8-year-old child who unfortunately had type 1 diabetes and who recurrently was admitted to the intensive care unit at the Johns Hopkins Children's Center with diabetic ketoacidosis, which you all know is out of control diabetes. Sick, oh, we could get her better, but it was 2 or 3 days of really being sick and an ICU hospitalization. So the nurse went out to the home. And here's what she found. She found that the mother, who was very devoted and very compulsive, was drawing up the insulin in a dark kitchen. She couldn't be sure about the accuracy of the insulin dose at all. Why was it dark? Tracy, you talked about electric bills. The electric had been shut off. So, is that something I know how to fix? No. But it's something that my colleagues know how to fix, in this case, social workers. We used to call that little girl a girl with, we have expressions for everything in medicine. And we used to say she had brittle diabetes. In other words, it was very hard to control, very hard to manage. After the electric bill was addressed, no more brittle diabetes. So that's why you need a team. And those are the experiences that I learned from. So when I go over on Tuesday afternoons to see patients, there's a motive other than the fact that, frankly, I like to see patients. It's very rewarding to me. Makes me feel good. Nothing wrong with that, I hope. When I go over to see patients, and I've done this since 2010, my longtime colleague, nurse practitioner, and I, we see patients with social work faculty, pharmacy faculty, sometimes other faculty, but importantly, students from every one of our professional schools. We're all together as a team, the medical students, the pharmacy students, the nursing students, the dental students, the social work students, sometimes a law student. Lawyers, I think you all know this, are sometimes very important parts of a healthcare team. Tracy, you're all suffering because I like to tell stories, but let me illustrate.
We love your stories. We love them.
Let me illustrate that last point. How did I learn that lawyers are an important part of the healthcare team? You may all know it, but I didn't. And this is a Baltimore type story. I, as a pediatrician, and everybody that does pediatrics knows darn well how to get the lead out of a kid when a kid is lead poisoned. Again, that's the easy part of the job. The easy part of the job when a child has lead poisoning, which has long been a scourge for us, is to put the IV in and use what's called a chelating agent, something that binds lead, and then it gets urinated out. And the kid is no longer lead intoxicated. And what did we used to do? After the kid was fine, time for discharge, you go right home. You all see the problem with that. A kid that's lead poisoned should only need to be treated medically once. The rest of the work is for a lawyer that knows how to get a landlord to comply with the law. So that's the typical story of how a lawyer fits in on a healthcare team. But the point I want to make in getting to what should be a crisp answer to your question is that, like everything else, you have to teach people how to work in a team. You have to teach healthcare professionals how to work in a team. You have to model it. So that's what I have the privilege and pleasure of doing on a Tuesday afternoon. And when we see patients, we see them as a team. And all that additional bunch of issues that I don't know how to take care of, because it's not something that my profession is educated to, good at, whatever. I have these wonderful colleagues. I have a pharmacist that can take a patient and take the time to explain why a certain kind of medication needs to be given 30 minutes before the child eats breakfast, or it won't work. That's so often forgotten by the busy physician. You need the pharmacist. Nurses, the whole essence of nursing education, nurses are teachers, apart from everything else that nurses do. Nurses learn to be teachers when they're educated as a nurse. You know what social workers do. You know what physical therapists do. But we need to bring them all together, appropriate to the kind of patients we're seeing, the conditions we're seeing, and let the team go to work.
It's true. And really asking those hard questions to the family to determine, do you have a working refrigerator where you can put your child's insulin do you have electricity? Those are really hard questions, but
Yeah, you can't just assume.
critical, right? Very
People
critical.
won't tell you.
No, they won't tell you, and very critical, and very similar to the work that many of our social workers, case managers, and nurses do at Healthcare Access Maryland to have these conversations, either telephonically or actually physically going in the home to ensure that these social determinants of health needs are met. So obviously, you just said it, a robust and talented healthcare workforce is essential to improving the health of Maryland. So what strategies, again, this is fascinating for our governor to hear, what strategies should our state's healthcare system be using to attract and retain healthcare providers?
Well,
I know
I'm
we've
sure,
had some challenges, especially in the primary care space.
uh, there are any number that I'm sure could be mentioned. Here's one of my favorites, where as a state, we have the right idea, but we have to resource this right idea better. Here's what I'm going to focus on in response to your question. We have too many areas of the state, some not far from where I'm sitting here in downtown Baltimore, and some in the farthest regions of the state, our rural areas, where we have insufficient numbers of healthcare providers for a whole variety of reasons. If we're honest with ourselves, the part of the city that I know best, having been so focused in my career at the University of Maryland, Baltimore, on the west side of the city, West Baltimore is terribly under-resourced in terms of healthcare providers. And look, we can bemoan that fact, or we can just acknowledge the fact that perhaps if we provided incentives, perhaps a few more would practice there. Ditto for rural areas. It's long been a challenge for rural areas of our state and any state to attract a healthcare provider, to attract a physician, for example, to attract that physician's spouse to a rural area and keep them there. So I mentioned incentives. Sometimes money does help. And you all know that healthcare providers generally graduate with debt. In many cases, a lot of debt. So happily, the state of Maryland has long had something called MLARP. Here we go with an acronym, MLARP, Maryland Loan Assistance Repayment Program. It is attractive to a budding professional to consider practicing in a needy area if the deal is that for a period of time, for every year they practice there, there's going to be a payment of their loan. Makes total sense, and it works. So we have that program. But there's way too insufficient number of dollars in that program to really make an impact. So this guy has long been going around to visit the legislators during session. Everybody cares about it, but we haven't moved the needle sufficiently. So that's the one I choose to pitch to you today, Tracy, in response to your question. Let's pay down these loans. Loan payment, loan assistance is on the national scene now. It's controversial. Lots of people have burdens, loan burdens, regardless of the kind of education they have. But you can use it in healthcare as an incentive to get to where you need to get.
Absolutely. And also recruiting and retaining individuals from the communities that they serve, right? So people that look like them, that are from the communities, that are serving people that look like them. So I know I'm going to talk about something that's near and dear to your heart. We have about 20 minutes left and a couple more questions, but I know that the UMB Cure Scholars Program is your baby. And I would love for you to share how the program provides pathways for youth to higher education and to experience STEM and healthcare. So what results have you seen from the Scholars Program? So I know you're going to talk about it because you love it, and I will certainly put a link in the chat for people to learn more.
Well, thank you, Tracy. So more stories. In having the privilege of being a medical school dean and in serving in an academic medical center, began to really appreciate a very big challenge that all of us in healthcare have. You use the expression that we all use. It tells the story, the importance of providers that look like the population they're serving. And why is that important? It's certainly important as an issue of social justice, as an issue of fairness. Of course, it's important in that regard. But for all of us who care about patients, there's something just as important. Some might argue more important in terms of correcting this problem. The medical literature clearly shows that, in fact, if you are cared for by somebody that looks like you, and let's stretch that out a little bit, somebody that comes from the same life experience, the same culture, I'll tell you a story within the story. What I just said. I've alluded to the fact that, and maybe I should have had her on this call, I've had the privilege of practicing for the last 25 years with a nurse practitioner partner. She is African American. And here's what I notice when we practice together. If I see the patient first, and the patient is an African American family, and we have a very good, what I think is a very good encounter and good communication. And then my colleague, who's a doctor of nursing practice, so I call her Dr. Steins, but my nurse practitioner colleague, when she walks in to meet the family, if I've seen it once, I've seen it 1,000 times. There's an almost imperceptible nod. Now somebody that's walked into the room is going to really get it in a good way. You know what I mean by get it. That has even been written up in the New England Journal of Medicine. So it's right there, what we were just talking about. You can see it physically. And as I said, what the literature shows is that when you are cared for by a provider that has something physically and beyond that, emotionally, experientially in common with you, the outcomes are better. Whether it's a woman of color with breast cancer or a male of color with prostate cancer, the outcomes are better. Now, that's a very complex issue as to why they're better. Is it biology? Is it the behavior of the provider, et cetera? But the outcomes are better. And since healthcare, I mean, what's the bottom line? The bottom line is the outcome, right? You want to get the person better. So we should all be invested in trying to make our healthcare professions look like America. And so those are very lofty statements, and then you have to do something about it. And what we've done, Tracy, is modest. It needs to be scaled. It needs to be adapted elsewhere. It's called, as you said, the UMB Cure program. Cure is not what you think it means in this acronym. because it came from the National Cancer Institute, which started a cure program 25 years ago to try to find minorities who could be helped in college, into graduate school, into healthcare research, ideally to find why we have so many cancer inequities. I mentioned two of them: prostate cancer, breast cancer. So we decided we'd have our own little cure program with their support here in Maryland. The cure program started in 2015, attracting kids from 3 middle schools in West Baltimore and getting them to campus 2 afternoons a week, Saturdays sometimes a visit to the operating room, no patient there, but with an anesthesiologist that looks like them, or an ENT surgeon who looks like them, for all the obvious reasons and purposes, to acculturate them to the possibility of a healthcare career, getting them to invest their interests in STEM, helping them with schoolwork, holding on to them for dear life through high school, and seeing them go off to college. Now, I don't know if one of them will walk across a medical school stage at graduation. I hope to be there to see it, but it's too early yet. But I'll tell you something, the first cohort of Cure Scholars that we started with, I just watched them go off to college. All of them that were left, 17 of them, all went to college. And I knew those kids when they were 11 years old. Obviously, I can't prove this because we wouldn't do some sort of a randomized experiment. But I will venture to say in front of all of you, those kids weren't going to college.
Gives me goosebumps, really. And I had the pleasure of seeing the documentary on campus, and I put it in the chat. So those that want to follow more and learn more about UMB Cure Scholars, it's really an amazing program. Thank you for bringing it to the University of Maryland and to West Baltimore students. And I foresee at least one student will go in, at least one. We're going to get one across that medical school stage. And I can't wait for the announcement of that. So, there's multiple communities across the state, right? We've talked about West Baltimore. We know the challenges in West Baltimore and across the city, but there's also other communities, Western Maryland, the southern part of the state by the shore. What communities are you seeing in our state with the greatest need to fill healthcare positions? I mean, we're struggling to hire nurses even here in Baltimore with HCAM, so I know it's a challenge.
Yeah, I think we're okay in our suburban areas. I don't think we're okay anywhere else. Everybody's got the challenge with regard to nurses, whether you're operating in a hospital in Western Maryland, Southern Maryland, the Eastern Shore, here in Baltimore. Sure. And frankly, I'm sure in our suburban hospitals who provide such good care, everybody's got a challenge with nurses. We've got to provide teaching programs, and we are, together with our community college partners in various parts of the state, make sure that the hospital environments makes as many teaching experiential opportunities possible for them so that we can keep nurses in each community. With regard to physicians, we will probably have to do some sort of a hybrid. It's probably the best model to get our physicians educated in terms of their basic sciences in a place where medical teaching is concentrated. But then again, make sure that they can get experiential learning in rural areas of the state. One of the programs that we have in this state, as in many states, is called AHEC, another acronym, Area Health Education Centers. And these provide opportunities for our healthcare learners to work in a rural environment. Hopefully, some of those students will catch fire with that environment, and then maybe we'll have a robust our loan assistance, our LARP program, to help them at least stay there for a while.
Oh, I couldn't come off mute. Yeah, there's definitely a lot on your plate. Recruiting new individuals to come and learn in the state of Maryland, making sure that they're connected to appropriate jobs. You do have a very large responsibility. How do you think University of Maryland system is addressing diversity and cultural competency, among the health professional students? And I know this is much longer than a 2-minute to 3-minute answer. Could probably be its own other speaker series. What are your thoughts on that?
Well, I think that our commitment to team-based care actually delivers on our commitment in many ways to making sure that our students are culturally competent. I like to be able to say that we are focused on putting out healthcare providers where it doesn't matter who is sitting waiting for their care behind the exam room door, or if it's in a hospital setting, in the hospital room when they come in on their shift for their first encounter with the patient. Our healthcare providers, I tend to use the word aplomb. They need to be able to care for anybody, regardless of race, regardless of ethnicity, with aplomb. Now, that's a tall order, but it's an expectation. And how do we get there? We get there by making sure that they are educated in an environment where they have to learn together with, where they have to interact with people who are very different from themselves. So the learning environment itself begins to prepare a healthcare professional for the larger world, in my view. And so we shouldn't be educating healthcare providers if we can't educate them within a diverse environment, an inclusive environment, an environment of belonging itself. And yes, it's a long conversation. Our strategic plan is a system which we've just promulgated for the next 10 years. Of course, it has diversity, equity, inclusion, justice in the plan. But we have made one very specific requirement in that plan. It's a goal in itself, DEIJ. But we also make it clear that in everything we do, there needs to be a DEI lens. In other words, we can say that, of course, a goal of ours is to provide an excellent education and to contribute to the workforce of Maryland and to do cutting-edge research that improves the human condition. Always think about DEI, no matter how narrow the objective is within those other pillars.
That's key, and thank you for saying that. We do have a question in the chat regarding how the UMB Cures programs, or any other programs for that matter, are marketed to the Baltimore City Public Schools to make sure that students know about these, and how do you find the students? I know you were focused in West Baltimore.
Yeah, those are excellent questions, and they go to the challenge that I think we all have. I described a program to you that in general and right now, and it's as much as we can do at that institution, has 125 students. That's wonderful, but I'd be the first to admit It's the proverbial drop in the bucket, isn't it? The question is how to scale it. Now, I will say that the Baltimore City schools have been great partners all along in this program. Dr. Santelises has supported this program 100%. We have total cooperation with the schools that we're in. What's needed is what's often needed in scaling something up: more resources, and with scale, the cost per student will come down. There's no question that when you have a small program, it costs you more per student, and it's too expensive. So we've got to find ways to scale this program. When I go around, you might imagine, and the questioner touched on this. When I go around the state and tell this story, I can't leave whatever place it is without somebody saying, often somebody in authority, saying, well, you're going to do that here too, aren't you? Well, we should. Of
course.
But it takes resources.
Absolutely. And it comes down to that often. And Chancellor, this has been just such a lovely conversation with you. I love your stories. I'm glad you had the opportunity to speak with us today. I'm going to give you a hard one at the end to wrap us up. One change that would improve the health and well-being of Marylanders. We all know it's not just one. So that's why it's a hard question for you.
Well, I'm probably not going to do what you want in giving you a narrow answer. It'll be brief, though. You know, if I could change the world, I would try to correct something that's frustrated me for too long. Most of what we do in healthcare, some of you may disagree, is trying to fix the problem. In other words, the child, the adult, they're afflicted already. And we're very good at, like the little story I told you about lead poisoning or diabetic ketoacidosis. Man, we can fix things good. And let me say, I understand that there are so many things that happen in terms of a person's health that we don't understand, that will happen anyway, in spite of what I'm going to say, that we can't prevent. But that's what I'm getting to. One of the reasons I went into pediatrics is pediatrics, it's all about prevention. Treatment of a child is the default. The art form is to keep the kid healthy in the first place. And I just wish that we understood that if we directed our efforts and our resources more toward preventing the problem in the first place, not only will it improve well-being, keep people from suffering, it'll be less costly.
Absolutely.
It'll be less costly. Nobody wants to talk about cost avoidance. You saw the article in the Sun this morning on the front page from Hopkins. I haven't read the study. I just read the article. I assume it's accurate. It was about kids with asthma. If you get them away from those social determinants of health that we've all talked about today, hey, they're just in the emergency room less. They're just in the intensive care unit less. Come on. That's all.
That was a brilliant answer, because I think, it is hard to narrow to one area. Again, Chancellor Perman, it has been such a pleasure to talk to you today in our third and final series of Making Maryland Healthier. I want to thank everyone who joined us today, including the Chancellor, our team members from HCAM to learn more, all of our friends and followers. There'll be a feedback link in the chat if you don't mind completing that for our survey. It'll help us define future speaker series and get your feedback on today's conversation. Follow us on LinkedIn, Instagram, and Twitter to know about our upcoming speaker series in the fall. And Chancellor, we'd love to have you back in the future if you'd like to join us.
I got more stories, so I'd be happy to.
Wonderful. Thank you so much for your time today. We appreciate it. Thank you, everyone, for joining us.
Thank you.